Hello friends, let us learn now about adrenocortical carcinoma. This is a rare malignancy which is seen that this may occur for 1 or 2 per million population. This is a highly malignant tumor. Though it is rare, it is highly malignant tumor. So let us see the causes. Most of it can be sporadic, and also there can be germline. First there can be somatic mutation in tumor suppressor gene. The tumor suppressor gene which is involved in adrenocortical carcinoma is TP53. And then there can also be germline mutation in TP53, and this can be a cause of Li-Fraumeni syndrome. In this, there are multiple solid organ cancers. In some pediatric cases, in some children, in pediatric cases there is TP53 mutation, and also mutation in R337 is found. And there is also evidence that whenever there is alterations in WNT beta catenin pathway may cause this adrenocortical carcinoma, and also alterations in insulin-like growth factor 2 cluster, and also IGF-2 insulin-like growth factor 2 overexpression can also cause this adrenocortical adrenocortical carcinoma. IGF, insulin growth factor, insulin-like growth factor. Now what do? There is a test. There is a let us see how does it look morphologically. The morphologically grossly morphology. So morphology grossly, it looks like a large spherical and well demarcated tumor and if you see the cut section, it is yellowish in color with, if this is the cut section, it is yellowish in color with the hemorrhages, areas of hemorrhages, and also necrosis and calcification. So there is yellowish with areas of hemorrhage, necrosis and calcification. It can occur from well differentiated to anaplastic growth. Now this microscopically it can be well differentiated to anaplastic growth. If it's anaplastic, there are large pleomorphic Bezier cells with high mitotic activity. If it is well differentiated, they will have just foci of atypia. So this is how we see morphologically the cortical carcinoma. The clinical features include the patient may complain, mostly they are asymptomatic, but sometimes they complain of abdominal pain and back pain. Okay, and in 60 to 70% of the cases there is increased production of glucocorticoids and mineralocorticoids. So increased production of glucocorticoids, the patient may manifest as Cushing syndrome, that is one, and increased mineralocorticoids, the patient can manifest as hyperaldosteronism. Okay, now there is a score for histopathological classification. There is a score that is called as V's score. This takes into account the high nuclear grade, mitotic rate of more than 5 per high power field, and then it also takes into account atypical mitosis and less than 25% of clear cells, diffuse architecture, and also presence of necrosis or venous invasion or invasion into sinusoidal structures and tumor capsule. So among all these elements, if 3 or more elements are positive, then this suggests adrenocortical carcinoma. That is V's score. There is one more staging, which is McFarlane staging for adrenocortical carcinoma. Here stage 1 is if the tumor is less than 5 centimeters. Stage 2, in this tumor is more than 5 centimeters. Stage 3 is tumor with local invasion, and stage 4, there is distant spread. So 5-year survival rate for stage 1 and stage 2 is 25%. For stage 3 and stage 4 it is 5%. Okay, this is McFarlane staging. And then Tnm classification, or there is one more staging which is associated with Tnm classification and NSAT staging. So I'll write that in my next page because that is a little longer one. So stage and NSAT stage, and also Tnm staging. Okay, so stage 1 is T1, N0, M0. Here T1 is tumor is less than 5 centimeters. N0 is no positive lymph node. Okay, M0 is no distant metastasis. That is stage 1. Then stage 2, it is T2, N0, M0. T2 is tumor more than 5 centimeters. N0 is no positive lymph node. M0 is no distant metastasis. Okay, that is stage 2. Then stage 3, it is T1 to T2, N1, M0, or T3, T4, N0, N1, M0. So T1, T2 already we have said it tumor is less than 5 centimeters or more than 5 centimeters. T2 is the T1. Then N1, it is positive lymph node, and then M0, no metastasis. Okay, and then T3, T4, T3, tumor infiltrating surrounding tissues, and T4 is tumor invading adjacent organs or inferior vena cava. Then fourth stage, it is M1. Any T1, T4 or N0 to N1, but there should be M1. So M1, there is metastasis. So I'll write this Tnm staging in a better way. So this is the one more staging which is available for adrenocortical carcinoma. So Tnm staging. T1, it is tumor less than 5 centimeters. T2, tumor more than 5 centimeters. If this is the adrenal gland and kidney, if this is the tumor, if the tumor is less than 5 centimeters, then that is T1. If the tumor is a little more than 5 centimeters, that is T2. Then T3, if the tumor infiltrates the surrounding tissues, that is T3. So if this is the kidney and this is the one, it is infiltrating, it is present in the adrenal gland and it infiltrates the surrounding tissues also, that is T3. And then T4, in this the tumor invades adjacent organs, that is 1, and there can be venous tumor thrombus in vena cava or renal vein. So in that situation, if you see, if this is the tumor, if this is the kidney, this is the adrenal gland, now this is the renal vein going into the adrenal gland, inferior vena cava. This is suprarenal vein which is draining into the renal vein, and now this is the renal artery, okay, which is draining into the aorta. Now what happens? Now there is a tumor, and this tumor may invade the adjacent organ, that may be kidney, or it can cause a thrombus in the renal vein or the inferior vena cava. So that is T4 of Tnm classification. Then we know N0, no lymph nodes, N1, positive lymph nodes, M0, no metastasis, M1, positive metastasis. So now, how do you diagnose it? Investigations. So you do FNAC, it is not done, not indicated. The reasons for not indicated is 1, FNAC will violate the tumor capsule and may cause needle canal metastasis. Okay, that is 1. Number 2, FNAC, it cannot differentiate benign and malignant condition. Okay, so we don't do FNAC. So for this we do first you can do chest X-ray and abdominal X-ray, abdominal ultrasound for local invasion, and lymphadenopathy and metastasis. So adrenal the origin of tumor in adrenals, origin of tumor is difficult to determine on standard CT, on standard axial CT imaging if tumor is large, then it is difficult to find out. So because of that, MRI is more informative. Okay, so MRI is done, and then in the MRI, whenever there is vascular and adjacent organ involvement, then you can say it is malignancy for sure. And then you can do one more scan, that is 18-fluorodeoxy glucose positron emission tomography. It is sensitive for detecting malignancy. And to detect small metastasis and local recurrence. Metastasis or local recurrence. So even the smallest metastasis can be found out by this 18-fluorodeoxy glucose positron emission tomography. But the main disadvantage is it is not specific and it cannot differentiate benign and malignant. Okay, then prognosis, it is poor. Cure is by surgical resection. Then the prognosis is more poor when there is capsular invasion or capsule violation during primary surgery. During primary surgery, if we violate the capsule, or whenever there is metastasis at diagnosis, and also primary treatment, and if primary treatment is given in non-specialist center, so all these will have poor prognosis. Surgery that we do here is en-bloc adrenalectomy. Okay, if it has invaded the kidney or spleen, then en-bloc removal of spleen and kidney decreases recurrences should be done. And then You will also have to remove tumor thrombus from inferior vena cava if it is present. Then you can give adjuvant therapy with mitoten. Adjuvant therapy should be given with mitoten. This mitoten is started at 500 milligrams QID and the dose is increased by 1000 milligram per day every 1 to 2 weeks. And the maximum dose is 8 to 10 gram per meter square per day. Okay, and this is continued for 2 years. Okay, and then this mitoten levels should be monitored. Okay, and therapeutic range of mitoten is 14 to 20 milligram per liter, and also neurotoxic complications occur if it is more than 20 milligram per liter. So we will have to monitor the dose very carefully. Mitoten also increases glucocorticoid inactivation. It induces hepatic CYP3A4 activity and thus causes increased glucocorticoid inactivation, and it also increases circulating cortisol binding protein. Okay, the circulating cortisol binding protein, it increases the circulating cortisol binding protein. This in turn decreases free cortisol fraction. When is there high risk of recurrence? High risk of recurrence is seen if the tumor size is more than 8 centimeters, or if there is histopathological signs of vascular invasion, okay, or if there is capsular invasion or violation, or if there is Ki67 proliferation index more than 10%, more than or equal to 10%. In such cases, there is high risk of recurrence. Okay. If the tumor recurs, then we recurs or progresses during mitoten therapy. During mitoten therapy progresses, and if the tumor recurs, then chemotherapy should be considered. And we give a regime which is called as Berruti regime. So here we give cisplatin, etoposide, doxorubicin, plus continuing mitoten. Okay. So if there is painful bone metastasis, So this will respond to irradiation. Okay, so these are the treatment options which are available for adrenocortical carcinoma. Now, what are the secondaries of adrenal gland? Let us learn a few points about secondaries in adrenal gland. So the secondaries in adrenal gland, it is common, and it is commonly from breast, lungs and kidney, and also melanoma. They can be unilateral. If unilateral, you will do adrenalectomy. If these are bilateral, you will have to treat them with chemotherapy. Okay. Now, what are the approaches, surgical approaches which are available for adrenals? Surgical approaches for adrenals. These include posterior lumbotomy, anterior transabdominal or abdominothoracic approach, or it can be laparoscopic approach or by retroperitoneal approach. So these are the different approaches which are available for adrenal glands. So thank you guys for watching my lecture. If you have any doubts, please comment it in the comment section. If you feel something is inadequate in this lecture, please comment it in the comment section. Please subscribe the channel for more videos. Thank you for watching my lecture. Thank you.